Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Adla, for this introduction. Thanks, organizing committee, presidents, dear colleagues, Prof. Sahar, for inviting me to join you in this conference. This is my first time, believe it or not, as a Saudi to Bahrain, so I'm really pleased to be with my family and my second country. So the objectives of my talk today is to recognize different clinical presentations of lupus, to interpret autoantibodies in the right clinical settings, to differentiate between lupus activity versus other diseases like infections, and to discuss basic principles of management of SLE. I know this is a general medicine conference, so I will just touch the basic principles that that internists to primary care physicians should be aware of, and review some recent updates. I won't spend too much time. I know it's not a specific rheumatology conference, it's a general medicine, so I'll just touch base on the recently approved or some of the common drugs that are used in lupus without FDA approval. So I like principles. I'm an educationalist, so I like teaching with principles. So principle number one for all of us, I think all of us agree on this, you have to confirm your diagnosis. Whatever disease that you are managing, you have to confirm your diagnosis. You have to determine clinical findings and autoantibodies profile. Why? Because certain disease presentations and manifestations has different management. Lupus it's a disease of 1,000 face and one face. So it has multiple clinical presentations, different managements for different presentations. So rule number two, or principle number two, for an acute presentation, you have to determine, is it lupus or complications of drugs of lupus or other things not related to lupus? And I'll mention for you a few examples as the presentation proceeds. And the last principle, so what is the suitable drug for lupus? And in pregnancy, what is the suitable drug? So if you know these principles, you know all what you need to know about lupus as an internist or as a primary care physician. Okay, so these are the slides. This is the summary that I want you to master by the end of this presentation. Principle number one, or what you need to know about lupus. ANA is a screening test, should be ordered in the right clinical setting, should not be used for monitoring. So we've been seeing many patients, me and Prof. Sahar and colleagues in rheumatology, patients, doctors are doing ANA frequently. This is of no value. Okay. Number two, SLE has a wide clinical, presentations with arthritis. We are rheumatologists, we are dealing with arthritis. So arthritis is the most common presentation for lupus, followed by mucocutaneous findings, so you should be aware of this. However, I'll be mentioning some rare presentations. And number three, to check disease activity, you need to follow clinical issues related to the patients. So if his disease is active, the patient will be aware. He'll have more joints pain, he'll have fatigability, things like that. Clinical is essential, and you have to check these parameters, and I'll be mentioning it later. Number four, refer patients early for kidney biopsy. And this is a common mistake that we are seeing in practice, where patients are supposed to have kidney biopsy 1 or 2 years ago, and they just get neglected. And number five, do not ever stop hydroxychloroquine in any lupus patients, even during pregnancy. This is a very common mistake. We are seeing it with colleagues, obstetricians, who stop because it's not safe during pregnancy. And you need to check anti-Ro, anti-La for any lupus patients who's planning to get pregnant. And I'll let you know in a minute why is that. And for any patients with lupus who has antiphospholipid antibody syndrome, she has to be on aspirin and low molecular weight heparin. Be careful, there are two states. There is a positive serology for antiphospholipid antibody syndrome, positive antibodies only, and there are people who have the syndrome with the clinical features and the antibodies. So we need to differentiate between the positive status and the syndrome itself. Lastly, be aware of the new drugs that have been approved recently in lupus. So, okay, let's start one by one. I hope the time, inshallah, I'll proceed quickly. ANA, as we said, it's a screening tool for someone with suspected lupus in the right clinical setting and should not be used in monitoring disease activity. As you all know, this is a common presentation for all arthritic disorders that we are dealing with in our daily practice. And the first one is the classical lupus presentation. It's a rheumatoid-like presentation where you can see the joints affected, the MCPs, the rest joints, the MCPs, the PIPs, rarely the DIBs. The DIBs are never involved in RA, almost never involved, and MTPs. So this is a classical clinical presentation of lupus. This is for ankylosing spondylitis inflammatory back pain Dr. Prof. Sahar was talking about. This also could be reactive arthritis. This could be psoriatic arthritis, okay? And this is inflammatory OA4, which is not lupus presentation. Okay, so we are dealing with arthritis, and these are the common arthritic disorders that we are dealing with. And this is the classical history, or the history that I was talking to Prof. Sahar earlier. Rheumatology, it's a comprehensive practice, and we need to take detailed history from our patients, and we are following this approach. And you can, I suggest for you to scan this, especially for residents, students who are joining us. This is one of the book that I was honored to edit. It's a free. It's published by Springer. The first chapter and the second chapter is widely used and read chapters about history taking, rheumatology, and physical examination. And I will show this slide later on, so if you didn't catch it now, you can catch it later. And the slides are available with the conference in the PDF format, so you can have this access, inshallah, easily. Okay, so I'll ask you right now, I'd like an interaction. So if a patient presents with polyarthritis, what sort of antibodies are you going to assess? Are you going to assess rheumatoid factor? Hands up. Rheumatoid factor, polyarthritis? No? No one? No interaction? Yeah, for sure. Okay, ANA, ACPA, anti-CCP. What about anti-double-stranded DNA? Sorry, what I'm doing. Okay, the other way around. Sorry. What about anti-double-stranded DNA? Are we going to check it in someone with polyarthritis? Yes? Okay, or anti-Smith, anti-Rowe, anti-Lam. Okay, so only 3 of them. You check the first 3. You don't need to check some misbelief that common misbelief among internists is rheumatology is all about autoantibodies. This is a big misbelief. We don't sit, me and Prof. Sahar, in the clinic and just checking the antibodies. It's a clinical specialty, for God's sake. So we do examine our patients, we do take history, and then we order antibodies and we interpret them in the right clinical setting. So it's a screening tool, ANA. You can check your lab how they are doing it. Some labs are lousy. Be careful. Either immunofluorescence or ELISA. Right now, most of the labs that I've seen in Saudi, they are doing it ELISA. But if it is immunofluorescence, the positive test should be more than 1 in 80, according to the latest classification. If the ANA is positive, then you need to check other extractive nuclear antigen. That's it. If NA positive once, you do not need to repeat it because it will be turning negative with treatment. So it doesn't mean anything. Patients initially diagnosed with lupus, NA was positive. 3 years, you check NA again, it will be negative. You say, no, there is no lupus. And the first doctor was wrong. This is absolute nonsense. Why? Because with treatment, NA will be negative. So that's why you need to determine NA at once. And that's it. You don't need to repeat it. Good rheumatologists do not repeat ANA. Okay, and then doesn't correlate with disease activity at all. Doesn't correlate. So just forget it. ANA positive ones, lupus, forget it. You don't need to repeat it. And I won't spend too much time. This is used to be classical. Me and Prof. Sahar are old school, so used to know this. But right now, I don't think no one is following these. But you have to be aware that anti-double-stranded DNA is very much highly specific and very correlated to lupus nephritis, anti-Smith as well, lupus nephritis, but not common in patients with lupus. Anti-Rowe, anti-La correlated with neonatal lupus syndrome. That's why I told you need to check it, especially anti-Rowe. You have to check it in any patients with lupus who wants to get pregnant. Okay, and so we have finished from the first thing that you need to know. Second thing, SLE has a wide clinical presentation with arthritis is the most common, followed by mucocutaneous findings. I already told you about the arthritis and the classical presentation of lupus as arthritis. And there is a case report. This is a case report 2007. Patient admitted to the hospital. He had fever, pancytopenia, and he remained in the hospital for 7 days without diagnosis. He had lupus. Why? Because no one asked him about morning stiffness. No one asked him to do range of motion testing. Yet this patient has bone marrow biopsy, had culture everywhere, and they couldn't find the etiology. But when they asked us to evaluate him, simple question, do you have morning stiffness? Yes. Can you do like this? He was having fixed flexion contraction in his elbow. So musculoskeletal examination skills are really essential to diagnose lupus properly. We did the screening among our internal medicine residents in the kingdom, around 700 residents, they 40% responded to our survey. 78% of our residents, they feel incompetent in musculoskeletal examination. Huge. This is not only in Saudi, it's international, unfortunately, literature supporting that we do not teach musculoskeletal medicine properly in undergrad and even in our postgrad training programs. Why? The problem still, it's not the time to talk about the details of that, but anyway, and one of my big areas of interest and research is to standardize the musculoskeletal exam, which I published and with a group of colleagues. We standardize the physical exam. You'll find it in the chapter in the book that I also ask you to look at. So you can scan it if you like. The second chapter is the most widely read chapter in our book, where we are talking about musculoskeletal exam, how to examine joints. If you are students or residents, believe me, this will be, inshallah, great help for you. And this is another study that we are publishing right now. Arthritis in our lupus cohort of patients are the most common lupus presentation, followed by skin rash. And just to, are aware of all these smeller rash and photosensitive rash, the discoid rash, this one of my patients, the hair loss, she did respond really well to belimumab. And renal carcinoma, this one, also one of my patients, I managed, this patient ultimately managed with rituximab. She responded well. And so be aware of rare presentation of lupus, hematological findings. So lupus with ITP, someone with an ITP, you need to check ANA because there's a cross presentation between ITP and lupus. 40% of lupus will have ITP. And neurological findings, transverse myelitis. If you have, there are 19 different neuropsychiatric syndromes in lupus. So neurology and neurological presentation, you need to check ANA. And also recurrent pregnancy losses, you need to check ANA. She might have antiphospholipid antibody syndrome secondary to lupus, or lupus and secondary antiphospholipid antibody syndrome. So what is the most common lupus-related finding leading to hospital admission? Why patients with lupus, if they are lupus-related causing admission? Neurological. This one in one study. So neurological findings are not common. They are rare, but up to 25% of the time, it is the commonest cause of lupus-related admission to the hospitals, and more common than arthritis or ITP or mucocutaneous findings. And stroke are really common, since the previous talk was about multiple sclerosis and things like that. So this is an excellent reference. I will not talk about it, how to manage, and there is the recent publication, the management of neuropsych lupus. The studies are really discounted in this area. Do you need to check for antiphospholipid antibodies in every lupus patient? Yes or no? Any lupus patient, should you check for antiphospholipid antibodies? Yes or no? Definitely yes. Definitely yes, because you need to know if this patient has risk of thrombosis or not. And what antibodies you need to check, these are written clearly in the latest rheumatologists like to keep you busy. Every now and then they produce new classification, new guidelines, confusing ourselves first and then confuse you. Everybody should be confused. Why should you have everything clear? You have to be confused. So this is the new guidelines. So this is the 3 different antibodies that should be ordered to diagnose antiphospholipid antibody syndrome. Okay. And so, number 3, check clinical activity first and check antidepressant DNA. Antidepressant DNA, it does go up and down with this activity. It does go up and down with this activity. So you need to monitor that as well as other parameters, CBC, if there is leukopenia, thrombocytopenia, particularly lymphopenia. It goes also, it's correlated to this activity, C3, C4, urinalysis for active urinary sediments and hematuria or RBC counts. CRP in lupus. If you have CRP that is elevated in lupus patients, think of infection until proven otherwise. CRP usually do not go high in lupus patients unless there is acute infection. Particularly if it is more than 80 or 100, definitely think of infection. If you have lupus patients and on steroid and there is fever, think of infection until proven otherwise. Very commonly, we see colleagues in internal medicine, whenever the patients with lupus, they stop thinking about medicine. They just, this is lupus. You need to evaluate comprehensively. Well, not every fever in lupus is due to lupus. It could be due to pneumonia, for God's sake. It could be due to UTI. It could be due to something else. So very commonly, I don't know what happened to internal medicine when they come with lupus patients and they have fever or anything else. This is lupus, rheumatology. Come and evaluate. Well, do what you're supposed to do. You are an internist, so you have to evaluate the particulars. So CRP, elevation, fever in someone with lupus and steroid, think of infection until proven otherwise. Okay, now number 4 that you need to do, need to be aware of kidney biopsy. These are the indications for kidney biopsy. Why I'm mentioning this? Because I'm still seeing until 2022, some doctors are reluctant to refer patients for kidney biopsy, or some, even nephrologists, they don't do proper kidney biopsies for legitimate indications for lupus. If a patient has more than 500 milligram or more than 1 gram with abnormal creatinine, so these are the classical indications for kidney biopsy. You are aware of the different types of renal disease. Lupus nephritis is a special entity. We can spend hours talking about it, and there are specific studies, randomized trials about it. But just briefly, these are the different types of renal diseases. The classical classification of lupus nephritis, number 4 is the most common one, diffuse lupus. This is an old one. There is an update one in 2018 where it changed from A, B, and C to, they changed it to activity, chronicity, and disease, where there are numbers given. And I mean, the work is marvelous between pathologists, rheumatologists, and nephrologists to help diagnosing these cases early on. You can check it on the slides. So what is the hallmark of diffuse proliferative glomerulonephritis? Is it subepithelial deposits, subendothelial deposits, or mesangial proliferation of pneumatocyst infiltrate? For the sake of time, it is subendothelial deposits. You can see the 3 layers of the endothelium, the basement membrane, the epithelium, and you can, so this is the fenestration where the antigen-antibody complex is deposited here, and this is the hallmark of lupus nephritis type 3 and 4, subendothelial deposits. Subendothelial deposits. Okay, so quickly, the most common form of lupus nephritis is type 4. Induction, what is the best drug? Anyone in internal medicine, residents? What is the best drug for induction therapy? Mycophenolate or cyclophosphamide. There are details. I will not go into that, but these are the common drugs that we are using for induction therapy. The best maintenance drug? MMF, mycophenolate, superior to azathioprine. There are specific definitions for remission or partial remission. I will not touch that. We shouldn't forget statin ACE inhibitor, hydroxychloroquine. Hydroxychloroquine, I'll be mentioning in a minute. It can stop renal progression, stop disease progression elsewhere, and has lots of advantages in any lupus patients. And this is a common mistake by nephrologists. They tend to stop hydroxychloroquine in patients with lupus nephritis. This is the, I'll leave it, we can check the slides, please. And this is the guidelines how to manage lupus nephritis. There is no time to go over this. So back to the principle, let's go focus now on principle number 3. We talked about infections, we talked about lupus and clinical presentation. Let's go talk about the drugs. Do not ever, please, internal medicine, do not stop hydroxychloroquine for any lupus patients. It's like, you know, there is water here, we are drinking water. Hydroxychloroquine for lupus is like water for a normal person. You believe it, you don't believe it, it is like that. Okay, that's my time off. Did I do something wrong? Okay, so I'm almost finishing. These are advantages of hydroxychloroquine, very important to be maintained in lupus patients. These are the guidelines for lupus. So you can see hydroxychloroquine should be maintained in mild, moderate, severe disease. This is non-renal, okay? And you can see steroids can be used anywhere from mild to moderate severe disease. The evidence is less with methotrexate azathioprine. Very strong evidence for the new drug belimumab. This is one that I want to talk about. Just want to highlight it to you. Mycophenolate as well for moderate to severe disease. Cyclophosphamide for severe diseases. Rituximab is an old friend that we're using it for severe resistant disease, non-lupus. Even renal disease, they have a meta-analysis. We published it. In lupus nephritis resistant disease, you can use rituximab. This is the guidelines. I'll leave it for you. Are you going to stop hydroxychloroquine during pregnancy? No, please do not stop it. And these are the drugs that can be used during pregnancy, very common referral that we are getting in rheumatology. What drugs should we use, should not be used? And I left it for you. You can see the green light here, all hydroxychloroquine, Imuran, non-steroidal, especially you should hold it at the last trimester. For males, methotrexate, just I want to bring it to your attention. We used to stop methotrexate years ago for male patient who wants to conceive 3 months before, but right now it's not recommended anymore. Still, male patients can take methotrexate and they can try to conceive. Okay, number 6, anti-Ro, anti-LAM for any lupus patients who plan to get pregnant, because there is special screening protocol at the age of 24 or 16 to 24 for complete heart block, subacute neonatal lupus syndrome. And for any patients with known antiphospholipid antibody syndrome, you should maintain aspirin and low molecular weight heparin. Okay. يا عمي خليك كريم increase it 2 minutes. So this is the guidelines here, anti-Ro, anti-LA, the screening, and if it is under the syndrome, if it is definite syndrome, then you have to have aspirin and low molecular weight heparin. Okay. The new approved drugs, belimumab. This is the drugs published, study randomized trial 2012, 2013, approved by FDA. The first, it's a biological drug, B-cell inhibition. Now recently published, we can use it in lupus nephritis because the original studies did exclude lupus nephritis and neuropsych lupus, but right now we can use it as an add-on therapy for the standard of care in patients with lupus nephritis. A new drug that is approved right now for lupus nephritis, prochlorosporin. It's a new calcineurin inhibitor where we do not need monitoring. It has an effect on different races, a good outcome, as an add-on therapy to mycophenolate. And also the, you are mean, guys. Just let me finish. I'm finishing. So interferon gamma. Okay. And as I told you, rituximab, and there is a new concept right now, double B-cell blockade with rituximab and belimumab. And these are the 7 things that I told you about. Thank you very much.